Good morning and good afternoon to all our colleagues worldwide. My name is Pedro Suarez. I am the Senior Director for the Infectious Disease Cluster at MSH in Arlington, US. MSH has been implementing TB and HIV projects during the last 30 years worldwide, and as part of our technical strategies, we work to integrate service delivery model to address the issues of different health problems, including the infection disease components, to ensure that we will provide quality of care and comprehensive service delivery model to all the TB patients worldwide. So, why are we now talking about the non-communicable disease like an important challenge for TB and HIV and malaria? The most important reason of the challenge for the non-communicable disease is the magnitude of the problem worldwide. According to international data, almost 40 million people died with non-communicable disease each year worldwide. An important proportion of these people died in the productive age, and this is affecting mainly the low and middle income countries with huge socioeconomic impact in the populations in these poor countries. To address this challenge, WHO developed an action plan for the period 2013-2020 with the goal to reduce in 25% the early mortality by non-communicable disease in 2025. However, there are several barriers to get this target. For example, the little money from the government side and the international community to prevent and to promote quality treatment for the non-communicable disease issues at country level, weak health systems, which is resulting in a weak quality of care and prevention for non-communicable disease in several countries, and finally, that there is not any framework to fit the non-communicable disease issue within the universal health coverage worldwide. Now, let us explore briefly the comorbidity between TB and non-communicable disease. The most important non-communicable disease which is affecting the TB control programs is diabetes mellitus. And now, on international level, we accept that diabetes mellitus is one of the 5 epidemic determinants for TB control for the TB epidemic worldwide. Just to illustrate the magnitude of the problem, over the 10 million TB cases notified worldwide in 2017, nearly 1 million of these patients were attributed to diabetes mellitus. It does mean that in some countries, the comorbidity for TB and diabetes now is more important than the TB and HIV co-infection challenge. And this is a new challenge that several TB control programs trying to really address without any experience in this specific issue. Let us present quickly the comorbidity between non-communicable disease and HIV. As a result of the success implementing the new ART in low and middle income countries, most of the people living with HIV in these countries are living longer, and then they are increasing the risk of developing non-communicable disease. Several studies have found that the people living with HIV are at an increasing risk to develop some specific non-communicable disease like cardiovascular disease, kidney disease, and cervical cancer. And recently, also the influence of the mental health disorders are really affect the capacity to retain to the patients to ART in several countries. Let us start the dialogue. We will present 3 country case studies which illustrate some examples about the integration of TB, HIV, malaria, non-communicable disease prevention and treatment. Thank you.
Good morning and good afternoon. My name is Dagu Jereme. I am a regional director with the Challenge TB project in Ethiopia. I'll be talking about a TB, HIV, and diabetes integration project, which is a pilot project implemented in 4 regions of Ethiopia. So diabetes mellitus is a significant contributor to the burden of chronic diseases, and we are expecting that the number of people living with diabetes will increase dramatically by 2030. And it's estimated that there will be about 400 million with diabetes mellitus globally. And about 30% of these people will be in low and middle income countries. Diabetes mellitus and tuberculosis, they share some important common risk factors, including some peculiar characteristics related with the symptoms. For example, diabetic patients with tuberculosis are often asymptomatic, and they have atypical presentations and poorer treatment outcomes. So as a result, we usually miss them in the health system. Any diabetic patient with tuberculosis can be missed unless we do some active searching. This also affects the treatment outcome, both in patients with diabetes and in tuberculosis patients. There is also some evidence which suggests that there is interaction between HIV infection and diabetes mellitus comorbidity, but this area of evidence is still weak, and there is a lot of debate and discussion going on globally. The objective of this project, the pilot project that we implemented in Ethiopia, was to demonstrate the feasibility of implementing an integrated approach for chronic disease and infectious diseases, with the ultimate goal of scaling up the integrated service delivery model, both for tuberculosis and diabetes mellitus. So we started with a small fund from Management Sciences for Health, which is called an INCH fund. Using that money, we supplied essential materials for diabetes clinics, including a glucometer, lancet, and alcohol swabs. We also distributed existing guidelines and SOPs for the TB-HIV integration activities. Based on those inputs, we developed a package of on-site orientation materials for clinicians working the TB and diabetes and HIV clinics. We also had support from the regional health bureaus and the hospitals at the time of the implementation of this project. So they assigned focal persons both at the regional health bureau and the hospitals. They also endorsed the proposed activity as part of their routine work in the selected hospitals. The project then started by sensitizing the hospital administration about the need for integrated services. This was followed by training of the health workers on the specific screening approach. Then we continued with our support by providing regular supervision and mentoring. During these visits, we also collected information and analyzed the data for generation of evidence. So the trained health workers, they did the screening in each of the 3 clinics. In the diabetic clinic, the screening was done only for TB because there was no clear justification to do HIV testing among diabetic patients because there is no strong evidence to support this. In the HIV clinics, we did screening both for the diabetes mellitus and tuberculosis, and in the TB clinics, patients were screened for diabetes mellitus and HIV. The regional focal persons actively contributed to this effort. They participated in the joint consultative meetings. They also monitored the progress of the project jointly with the project team. So this implementation happened in 4 hospitals in Amhara and Oromia regions. These are the 2 largest regions in Ethiopia out of 11. At the time of this project implementation, we were also implementing a large USAID-funded project called HIL-TV. So we used the opportunity to embed this activity within the ongoing broader support during that period. So TB screening was done using a symptom-based screening approach, which is a commonly used approach, which was followed by a diagnostic test, mainly microscopy. We didn't have adequate infrastructure to do a gene expert at the time of this implementation, and also there was limited experience with using gene expert as a primary test at the time of this implementation. HIV screening and testing was done according to the national guidelines, so we used rapid test kits to confirm HIV diagnosis. The diabetes mellitus screening was a bit more complicated because we didn't have any proven tools at that time. So we used both a risk scoring system, which was adopted from the published literature, and a symptom-based screening, which was developed by our team. Diagnosis of diabetes mellitus was confirmed by 3 approaches. The first one is a fasting blood sugar with a cutoff point of 126 milligram per deciliter in TB patients. We use a fasting blood sugar in TB patients because these patients come early in the morning without taking any food, so we use that opportunity. For the HIV patients, we use a random blood sugar because there is no such a guideline for them to come without having food. And we also took having a non-diabetic status as a confirmation of diabetes mellitus. So this is an example of the diabetes risk scoring is an example of some of the tools that we used, developed and used there. It had components including family history of diabetes mellitus, yes or no, age group into 3 bands, hypertension, yes or no. We also had taken waist circumference at different cutoff points both for men and women, current smoking as never or ex-smoker or current smoker, and the use of alcohol, where the criteria used to make a composite index of a total score. So any patient with a cutoff point of 5 or more, with a total score of 5 or more, was categorized as a high-risk patient. We had some challenge during the implementation, expectedly, and some of the challenges include the service setup at the diabetic clinic was more complicated, and the symptom-based screening that we wanted to use among diabetic patients was not an efficient method to detect tuberculosis. So we suggested to use chest X-ray as an initial diagnostic tool, but this was never implemented during the pilot period because of also shortage of resources at that time. There was also no organized clinic for diabetes mellitus, as these patients are treated everywhere. So we distributed the registers into several clinics in order to organize the services. And recording and reporting was also lacking in the diabetes clinic, so we suggested to prepare a separate reporting and recording tools for TB diabetes patients. In the HIV and TB clinics, the challenges were slightly different. There was no proven screening tool for diabetes mellitus. That was the main challenge. So we used both symptom-based and risk scoring system until we have a more validated tool for diabetes screening. The ART clinic, the main challenge was the workload. So we engaged nurses and annual supporters to do the screening because the physicians were often busy with more complicated and other commitments. We also shortened the questionnaire in order to allow more time to screen more patients. So the results are summarized here, and we screened nearly 900 patients in the diabetes clinics, and the TB prevalence was about 0.7%, which is about 3.5 times the national prevalence estimate for Ethiopia at the time of this pilot project. In the TB clinics, we had smaller number of patients, but the proportion of patients with high fasting plasma glucose levels were 32%, and co-infection with HIV was about 12.5%. In the HIV clinic, we had more than 2,000 patients screened, but the proportion of patients with high plasma glucose were very small at 1.5%. And co-infection with TB was 15.8%. So in summary, this is one of the earliest or the first experience in implementing integrated screening for TB, diabetes, and HIV. We think that this approach could be feasible in settings with dual burden of both communicable and non-communicable diseases. If we scale up this kind of approach, it may serve as entry point, not only for identifying tuberculosis, but also to identify and manage diabetes mellitus and other chronic diseases. We also recommend further studies, the implementation experience, in order to identify best screening algorithms and treatment outcomes in patients with comorbid conditions. There is a paper published on this topic, and the readers are advised to refer to this link. It's published in the International Health, and it's also freely accessible. Thank you very much.
Welcome, everyone, to today's presentation on integrating mental health into ART adherence services. The presenter is Amechi Okafor from Nigeria. Problem statement. Achieving high rates of ART adherence is a serious challenge for HIV treatment programs in Nigeria Approximately 20 million Nigerians suffer from mental illnesses, and the prevalence of depression among people living with HIV was 23.1%. This figure is slightly higher than the figure reported in the general population. Depression among people living with HIV negatively affects their adherence to ART, which equally leads to poor retention. 46.7% of the total population that are depressed were mildly depressed, 50% were moderately depressed, 3.3% were severely depressed, while 40% were within the age range of 30 to 39. Appropriate mental health interventions reduce the negative impact of mental health disorders and depression. The project overview. MSH implements the USAID-funded care and treatment for sustained support, otherwise known as the CAS project, which runs from 2016 to 2018, to support the maintenance and the uninterrupted delivery of quality HIV/AIDS and TB care and treatment services integrated into Nigeria's health system. The CAS project operates in 41 comprehensive health facilities and 87 PMTCT sites in 5 states of Nigeria. The states are Sokoto, Kebbi, Zamfara, Niger, and Kwara. Our strategic approach. CAS project collaborated with Gede Foundation to facilitate the integration of mental health services into ART adherence services to create a one-stop shop for clients. To facilitate the implementation of this integrated model of mental health care for people living with HIV, the CAS project trained service providers on recognizing signs of mental disorders. Service providers were equally trained on appropriate counseling information for clients. Then we adapted screening tools for use by service providers. We equally created referral networks to link clients to mental health services, and we also trained adherence counselors to screen and identify patients with common or primary symptoms of mental disorders while providing adherence counseling services. Implementation. First of all, we mapped out supported facilities and skilled staff who can provide mental health services to people living with HIV. Then, various levels and stages of capacity building sessions were facilitated for these select service providers. The service providers screen clients, provide counseling, and as needed, escort suspects directly to the psychiatric clinic instead of giving them referral forms to go on their own. Facilities without psychiatric facilities make referrals to other facilities where psychiatric services could be obtained. Then adherence counselors are an ongoing link between ART and psychiatric clinic, facilitating communication, documentation, and follow-up. Then the sample of our screening form, the screening form we adopted for screening mental health disorders among people living with HIV has some basic information with the basic requirements. Some issues like the facility name, the date of visit, the name of the client, the state code, the facility number, the enrollment number, and so on are the information contained in the assessment form. During screening, clients were taken through different sections, which has to do with general appearance, the memory, concentration, the speech, the focus, and then some other areas through which we can indicate if someone has the symptoms of mental disorder. So if a client answers to 5 of the screening questions, that leads us to suspect that the client may have mental disorders. Then we refer for further psychiatric evaluation. Then the results of our intervention. 70 personnel have been trained on integrating mental health with ART adherence services. Out of these 70, 55 were service providers based at the health facilities, 10 were MSS staff, while 5 were government of Nigeria counterparts. Then 319 clients have been screened between August and October 2017, and 87% of the total population screened are women. Out of these 319 that were screened, 56 were identified with mental health related disorders, and this represents 17% of the total number screened. Out of this, 89% were women. Then 38 of the total number that were identified were referred for treatment, and they completed their treatment. 86% of those who were treated were women. The lessons and the implications from the intervention. With this integrated approach, clients receive multiple services in one clinic visit. A client who comes for a normal drug refill or for adherence counseling or PDP services uses the opportunity to access mental health services as well. Instead of going home and coming another day, the same clinic day is used to provide multiple services in one visit. So this saves time and the cost for the client. The number of times the client is supposed to go and come back for different services were integrated into one, and the equally saves cost for the client. The cost of transporting to and from the health facility is reduced to one visit, and that one visit is used to provide different services to the client. Not all mental disorders require medication. Proper counseling is key. There are some clients that require only counseling. Early stakeholders engagement is crucial to successful service integration. Before starting the services, it's key to engage government counterparts, the Ministry of Health, and the other line ministries that may be necessary. Then the service providers at the health facilities, equally people living with HIV in their support groups to make them know that these services are available for their members to benefit from. Then the head of health facilities. The combination of these ensures a successful service integration. Education and awareness is key to the reduction of stigma and discrimination associated with mental health disorders. The service providers were educated and sensitized on the importance of reducing stigma and discrimination against people living with HIV who are equally living with mental health disorders, because it amounts to double stigma for them, dealing with the issues of stigma that has to do with HIV, and then added another stigma and discrimination that has to do with issues of mental health disorders. Thank you for listening to this presentation. I hold on for your questions and contributions.
My name is John Mhari from MSH Malawi office. I'll be discussing malaria in pregnancy and NCDs, opportunities and challenges in Malawi. We have seen over time that in Malawi there is limited commitment towards NCDs, both at the national level and at partner level. We haven't seen high visibility or a lot of resources being put into NCDs. But at the same time, we have seen that the Ministry of Health has given a high priority to malaria pregnancy using the FUNK platform. At the same time, the government is moving forward in trying to pilot MIPSEPs at the community level. What's the FUNK platform is a very good platform. We don't see a comprehensive NCD screening process taking place during antenatal service delivery, but at the same time, we have seen that the Ministry of Health in its policy supports the screening of malaria. However, we haven't seen resources being put into test kits for anemia. As such, not all women that are going through the ANC are being tested for anemia. But at the same time, we are cognizant of the fact that malaria does induce anemia in pregnant women, which results in significant harm both to the mother and the baby. We also have to be aware that nutrition-induced anemia is a big problem amongst pregnant women, and more especially in Africa and Malawi as a country. We are having this as a big problem. In all this, there's still an opportunity that we can bring NCDs on the FUNK platform. As we know that malaria in pregnancy is supported through the delivery of ITNs, provision of SP as an IPTP to women that are coming to antenatal, and prompt case management. So there's an opportunity that we can encourage, we can work with the Ministry of Health to begin testing for anemia at antenatal clinic. Since we know that IPTP or SP that is given to women helps to reduce the problem of anemia that can be induced by malaria. So testing of anemia would complement and help to see whether the SP is indeed working in women. But there's an opportunity as well that we can, during ANC, create an opportunity for screening of NCDs. Could be anemia, as I've already stated, and other NCDs, which would make the mother more susceptible to malaria infection. There's already close collaboration that exists between the National Malaria Control Program and the Reproductive Health Directorate in Malawi, which provides an opportunity for the NCD unit, which is already available in the Ministry of Health, to join hands, work in close collaboration with these two units, and use the existing fund platform in order to deliver services for NCDs. But also we are aware that services here in Malawi are highly provided on an integrated platform, or one of which, as I've said, is the fund platform. And MIP services are built on that integrated platform, where a number of essential health package of services are provided at all levels, be it at the community level and be it at a facility level. Now, equally, the maternal health component is built on a continuum of care from the household up to the facility level. At the household level, at the community level, we have a well-functioning community-based maternal and child health service, where also issues of anemia can be easily tackled by community health workers. And that goes up to the facility level, where we have the already existing fund platform, which is a well-established platform that is providing incredible services and that has a well-functioning system, including well-trained nurses and clinicians who would be in a position to provide services to women as well as NCD services to women that would come to antenatal clinics. The use of screening for anemia can be used to leverage high-level support to prevent malaria in pregnancy. So we can also think of beginning to screen for other conditions, including NCDs. Could be hypertension, could be diabetes. So there's an opportunity here on the already existing integrated platform that is there within the Ministry of Health. But also, as I've already said, that promoting integration of the essential health package would also provide an opportunity for the fund platform or the ANC services to screen for NCDs, which are a growing problem in the country. Diabetes is a growing problem, anemia is a big problem, and all other NCDs are becoming a big problem amongst the pregnant women who are already vulnerable to these conditions. But then how does the malaria and pregnancy platform work, and how can we use it to bring in NCD services? As I said earlier on, the National Malaria Control Program works in close collaboration with the Reproductive Health Directorate, who are the custodians of the fund platform. So when there's a new direction from WHO, or when there's a new recommendation from WHO, I would give an example of the 2012 guidance on IPTP, that countries can move from 2 doses to as many doses as possible of SP. Then the National Malaria Control Program and the Reproductive Health Directorate worked in close collaboration. They developed the big policy and they developed the guidelines that led to the development of training manuals that have to be used to build capacity amongst health workers. Subsequently, they trained trainers of trainers who had to cascade the trainings to facility level and to even the community health workers. Just to make sure that the service is provided according to standards, they factored in performance and quality improvement processes, supervisions, mentoring, and coaching. And at the community level, they made sure that SBCC messages are there, communities are mobilized, communities are sensitized, and are aware of the change. So equally the same, the NCDs or the NCD unit can use the same platform, come together with the Reproductive Directorate, the National Malaria Control Program, or other stakeholders that may be interested in NCDs, develop the policy, guidelines, manuals, or job aids, do the trainings, orient health workers, and use the already existing platform to deliver the NCD services which are in need. Women we know are in need of those services, instead of maybe having totally vertical service somewhere, but just bring it on the fund platform. Now, let's look at the maybe what we can call the evidence-informed platform for action. As I said, in 2012 up to 2013-14, the MIP policies, the malaria and pregnancy policies, were adopted, implemented, and they're even now going to be implemented at the community level. So at the facility level, using the existing FUNC platform, when there was a change issued by WHO, 2 units work together. Within a year or 2, they develop guidelines, training manuals, and they implement it. And now the government has seen the need that IPTP can even be delivered at the community level. And the government has given a go-ahead. The IRB for the feasibility study has been given to MSH so that they can pilot delivery of IPTP at a community level. This is as a result of a collaboration between 2 units, reproductive health and NMCP, trying to offer services at an integrated platform. The same can be used for NCDs. We can start at the FUNC platform, see how it works. We never know. The government might be even so keen that these services can even go to our community level. There are already structures that are there from the community level to facility level, and that would be maybe the way to go. As a result of this collaboration, use of the integrated platform to build on other services, over the years we have seen that antenatal attendance has increased amongst the women that are completing 4 visits from 19% to 24%. This is just the recent malaria indicator survey. Equally, we have seen that IPTP3, which was just introduced a few years ago, it was 13% in 2014, 30% thereabouts in 2015, but in 2017, it's 14%. The National Malaria Control Program haven't used any other panel structure. They're simply building on the FUNC platform, which is well established and is able to deliver. But what it took for them is to come up with manuals, orient the staff, build capacity among the staff, the already existing staff, then the service is being delivered. And the way forward, we should be aware that malaria could be an indication of another underlying problem in pregnant women, and this could be an NCD. We need to coordinate and collaborate with, let's say, the NCD unit and other units within the Ministry of Health and integrate among partners in trying to build capacity for health workers, update policies, and maybe update guidelines so that NCDs are also incorporated in this platform. It will be important that this high-level support emanates from the government and other partners, could be USAID, PMI, or other interested partners in the areas of NCDs, and that also includes funding, and that is so important. So if we build a collaboration between these partners, we can move forward and work on integrating NCDs on this FUNC platform, which will be so important. And maybe we can start slowly by screening, emphasizing or strengthening the screening of anemia, and that maybe can be linked to multiple illnesses, including NCDs. Thank you.